Good morning.
Morning. Okay, so I think we're just going to get started here. Sorry, you're going to have to forgive rustling papers. I still rock it old school with printed out notes. So just introduction, I'm Desta. I work as the Research Ethics Coordinator in the Research Ethics Office here at St. Mike's. I've been here for just under 3 years. I think before that I was at SICKIS working in regulatory affairs. So the presentation I'm going to give today is on common concerns that come up when reviewing REB applications. And so because this is focused towards the knowledge translation group, I'm mainly going to focus on issues that come up during delegated reviews, so ignoring all the clinical trials type stuff, and also particularly for research that involves focus groups, interviews, questionnaires, and survey type research, because I think that's the bulk of what happens with the knowledge translation team. And so the aim in discussing this is that the common concerns will be addressed, and I can give some tips on how to address them when completing the initial application. Hopefully that'll lead to fewer review questions and fewer rounds of reviews, and the end result being faster approval of the application. So first I'm going to just start by going through a really quick overview of the REB and the application process, and then get into the concerns. If you've got any questions as I'm going along, about the slides, feel free to ask them, and also I can just take general comments at the end. I can't promise I'll know all of the answers, but I'll do what I can, and I can get you the answers that I don't know. So just quickly a bit about the REB. The main purpose of the REB is to ensure that all research involving humans, their data, or their biologic materials conforms to applicable scientific and ethical standards. And this can be anything from local St. Mike's policies on data retention or sending an email to international GCP guidelines. So to do this, we review all proposed human subject research at St. Mike's, and we monitor it throughout the duration of the study. So we get annual reports, we get amendments, we get protocol deviations, safety reports, anything that happens during the life of the study we want to know about, and we'll review it and take a look at it. We also get asked a lot about if, I guess phone calls asking, this is what we're doing, is it research? Or is it QI? There's a bit of a gray zone, and we understand that. Generally, if something is local, it's minimal risk to the participant, and the primary purpose of doing it is to improve care or service at St. Michael's, that tends to fall under quality improvement and would go to the quality improvement team. If it's something that's more like a systematic approach to create more generalizable knowledge, or it's multi-center, that tends to fall more on the research side of things and would come to the REB. So just a quick overview of some of the guidelines that we follow. So as mentioned, we're guided by everything from local policies to Catholic health ethics guidelines, because we are a Catholic institution. So that usually comes up with things like reproductive risk. So talking about contraception, stuff like that isn't really good. We have to be careful about how we discuss that in research materials. And then, so of the full list, the ones that are most applicable to delegated review studies are TCPS2 and GCP. And that's what we ask anyone who's conducting research at St. Mike's to be trained on. And so before you begin work on a research study, we'll require proof of training in both TCPS2 and GCP. And there's actually a new version of GCP that just came out, so it's like revision 2 guidelines. So those, I think, came out late last year, and they're the process of being adopted worldwide. I think Health Canada has an April 2018 target date for adopting it. City, GCP, who most of the training gets done through, has updated their modules to include R2 of GCP, but for right now, at least the REB, we're not asking everyone to go up your training. It's just as your training expires every 2 years, when you do the refresher course, it'll include the R2 component. So for now, nothing to worry about on that end. So the REB, when we review an application, they conduct an ethics review as well as a modified science review, looking at things like scientific merit and feasibility. And so the board has members that have scientific expertise in a variety of areas, and we assign reviews based on that. And one of the reasons, like an ethics board is looking at science stuff, is because at a certain point we have to believe that the study is feasible and it'll produce usable information. Otherwise, it would be unethical to subject people to research and interventions for no real outcome. And then in terms of the ethics review, we follow the 3 core principles of TCPS2, which are respect for persons, which is respecting their autonomy and their ability to decide for themselves whether or not they want to participate in research. And it involves concern for welfare. which is aiming to protect the welfare of participants by not exposing them to unnecessary harms, to minimize the harm that they're exposed to, and taking a look at the risk-benefit ratio of a study and making sure that it's proportionate and in line with this concern for welfare. And then the last bit is justice, which is the obligation to treat people fairly and equitably. So distributing the benefits and risks of research studies among all populations, so not excluding people who don't speak English just because it might be difficult to get a translator, or blanketly excluding women from clinical research trials because they might be pregnant and they might become pregnant, and there's potential reproductive risks because the burden of research should be shared among all groups as possible, but also the benefits of research. So you can create knowledge about just one very small group rather than a larger cross-section of the population. That's also not, doesn't fall within the principles of justice. So those are sort of the things that we keep in mind as we review an ethics application. The reviews that we conduct are proportionate and based on risk level. So anything that's deemed greater than minimal risk, so drug or device studies, surgical interventions, and also genetic studies usually get reviewed by the full board at bi-monthly meetings. Everything else is reviewed in a delegated review process by a board member, which is usually one of the chairs, and the research ethics coordinator. So these are usually qualitative type studies with interviews, focus groups, or observation studies. There's some cases where you might be doing an interview, but you're looking at a particularly vulnerable population or a sensitive subject area, and in that case, the board member doing the review might recommend that it go to full board. It's very rare, but there have been a few instances where those have been bumped up just because of the nature of the group or the types of questions that were being asked of them. So this is just a small overview of the submission and review process for a delegated application. So the research team submits the application. It gets sort of screened at the desk by usually our administrative assistant or one of the coordinators at the desk. And they just do a quick high-level check for completeness. If it's not complete, we won't accept it. We'll send it back with you to complete and resubmit to us. Once we accept it for review, it gets reviewed by the board member. Again, it's usually the chair or the vice chairs. They make their comments and then pass it on to the research ethics coordinator. The coordinator also does a review of the application. We're looking for accuracy, so matching ties it up with what the protocol says, completeness, are there complete answers to all of the questions, and also some ethics and privacy concerns. And then we will write the review letter and send that on to the study team. The team responds to the review, the coordinator reviews the response, and that can sometimes kick off a couple rounds of back and forth until the response, all the items in the response are satisfied, at which point we recommend the study for approval and pass it on back to the person, the chair who reviewed it. They, at that point, they take a look at all the responses and they can say, actually, no, I don't think this was answered adequately, and then kick it back for another round of review. That doesn't happen often. Usually between the research team and the research ethics coordinator, we're able to resolve everything to the satisfaction of the chair, but occasionally there is a question, but it's also, again, if there is, it's usually just like a very simple, straightforward question, like asking, please confirm that this will or won't be happening in a study. So at that point, they'll sign the approval letter and it's available for pickup, and then once you've actually got the letter in your hand, that's when you can go ahead and start the study. In terms of timelines, generally we aim to have the review letter out within 3 weeks of receiving it, and we aim to have responses reviewed within a week of receiving them. Obviously, sometimes workloads can get a bit heavy, so we can't quite meet that, but that's our target and what we aim to do. And so you can see, as I mentioned, it takes usually about a week for us to get to a response to review it. So the more rounds of review that your study has, like if it's the coordinator for a week and if it's the research team for a week, it really can add up and increase the length of time till the study is approved. So to reduce this, if the application proactively addresses the common concerns, there's less of a chance of ending up in this never-ending feedback loop. So without further ado, we will get into some of the common concerns. So submission screening. So this is the first initial check. This is really just getting your application in the door and accepted for review. So one of the things we check for is that the correct version of the form is being used. The TASN hasn't been updated in, I think, 4 or 5 years, so that's not usually a concern for the TASN, but things like the submission checklist, we actually do update fairly regularly, and often people will just pull up the latest version that they have already like saved on their computer or that they used for the last study without checking that there's a new version available on the website. So I would really encourage you to regularly check the website for new versions of forms, like submission checklist amendment forms. And because one of the reasons we update the form is because we find that we weren't getting the proper information out of it. So if you use the new form, we'll be getting that information from you and we won't have to ask it. Also missing signatures, so before we accept it, we check to make sure that the PI, the COI, and department head signatures are all present. We'll also do a high-level check for missing documents, so the protocol, consent form, data collection form, and anything else that you have listed on the submission checklist. We probably, if you're missing your like invitation email, we're not going to notice that it's screening. That'll be something that gets picked up later. And then lastly, the complete submission includes 2 copies of the submission checklist and 5 copies of the complete application. And we actually send you back with 1 copy of the submission checklist and 1 copy of the complete application. We only keep 1 submission and checklist and 4 applications. And the reason we do that is so many times in the last year or so, study teams have been calling us, asking us for copies of their protocols or their consent forms because they didn't keep a copy. So this is our way of making sure that at least on day 1, study teams got a copy of their protocol and what they submitted to us. Yep.
Question. Is it 5 or 4 copies?
It's 5 now. So it used to be 4 copies of the complete package and 1 copy of the submission checklist, but we bumped up to 5 and 2 because we're going to send you back with 1 of each to make sure you have it. Just a quick note here on signatures. Our signature policy, and this applies to all of submission types, initial reviews, amendments, annual renewals, etc. The principal investigator signature has to be an original ink signature or an authenticated electronic signature. So one of those like Adobe password protected type signatures. It can't just be a scan or a JPEG. And the reason we do that is because we have no way of knowing who's applied the JPEG to the study. And we need to know that the PI is aware of the submission and supportive of the information in it. If it's just a scan, we really can't tell. So we need something that shows us at least that the PI saw this application and approves of it being submitted. So, and then again, also if the PI is unavailable, like if they're on vacation or something like that, we will accept a COI signature with justification provided the PI didn't sign it. We won't check this part, but that responsibility should be delegated to the COI on the delegation log, or on the delegation log, to just make sure that on your end that's sort of covered off. Then in certain extenuating circumstances, like if the PI is unexpectedly away or there's an urgent amendment for safety reasons, we may accept a research team member's signature, but we're usually going to also ask that comes accompanied by an email from the PI saying that they're aware that something is being submitted on their behalf. If it's really like urgent, like an authenticate where the PI was in the Australian outback, we can again work with you on that, but again, it's really a really rare case. And just a quick note on a complete submission. So high-level screening won't catch every document that's missing, but to ensure we can do a full review the first time, please go through your study and make sure that you consider the following things that might be submitted with the initial application form. So your data collection forms, that's anything that's being used to collect study data, so like demographics forms, or if you're recording the data directly into a database, a list of the data fields is fine. Recruitment materials, so emails, posters, social media posts, flyers, telephone scripts, a Goodyear blimp, whatever it is, just make sure that anything that's being used to advertise your study or invite people to participate, we see a copy of it. And then also any participant-facing materials, so emails and letters, but also if you've got study visit reminder cards or user instruction manuals, or if they're being asked to compare 2 review types, we want to see copies of the 2 reviews that they're being asked to look at. So anything that the patient sees, we also want to see.
What about like a Twitter tweet?
A Twitter tweet, yeah, we would want to see that. It's
like, would you just want like a screenshot or?
Or just, or it could just be the text of it, yeah. So yeah, but we would definitely want to see that. We also want master logs, screening logs, enrollment logs, basically anything that you're going to record identifiable information on. And also training certificates for anyone who, if you've got a research team member who's like a student who did their training at McMaster's Day, we'd want hard copies of their training certificates, because we won't have access to that through our downloads that we do for the St. Mike's people. Things that we sometimes get that we don't really need to see are study team SOPs or delegation logs or user manuals for the study team to use, like how you calibrate your pipettes has very little ethical implications, so we really don't need to see that. And so that's just sort of things to keep in mind, so we can review them the first time around rather than having to ask you for them in the first round review, then having to review them, and then creating additional rounds of review. So moving on to the submission checklist, this isn't really an imperative point, just makes our life a little bit easier. When you're completing it, if you could just make sure to put the correct version dates and version numbers on the checklist, because that's what we use to enter all of the documents into our own Access database, and if we can just go off this sheet rather than having to thumb through all of the pages, it just makes life a little bit easier for us. Okay, this is mission checklist. It also has a section for listing everyone with training. So in this section, list everyone who's doing research activities at St. Mike's, but also only people who are doing research activities at St. Mike's. So a lot of times we'll see co-investigators at other institutions will get included here, and they don't actually do anything at St. Mike's, but because they're listed here, we ask for training certificates and stuff like that that we don't actually need because they're not here. So this is just for people conducting research activities at St. Michael's Hospital, or I guess, or on behalf of St. Michael's Hospital in the community, but under the jurisdiction of the St. Michael's Hospital, REB. Also list all of the tasks that they're doing so that we know who's doing what. And one of the main ways that we use this is to determine training requirements. So for example, if someone's doing data analysis only, like they've got no participant contact, no access to identifiable information, they only need TCTS2 training, not GCP training. So by having that information there, it helps us determine what sort of training we're looking for people. So all applications need to have department head signatures on them at the time of submission. This is one of the things I mentioned that we screen for. We generally won't accept it if it doesn't have it. Just as a reminder for the knowledge translation group, Dr. Ramlackhansingh is the person who signs off as the department head. I think in the past it was Dr. Slutsky, but recently we were told it has to be Andrea, so we'll just move that way. If the department head isn't available, for example, they're on vacation or something, it should be signed by like their official designate, not just somebody else in their department. So it would be like the person who's signing for them for all other matters while they're away. It can't be someone on the research team like the PI or the COI. And if the PI or the COI is on the research team and is the department head, it should be signed by someone at the next level up rather than their designate, because at that point you're asking someone who reports to you to attest to the fact that you're competent and qualified to conduct a study, which I guess could be a bit awkward. Overall, okay, this section is a big one for us. So in it, the overall study design should be described, include all study procedures that are happening. If it's a multi-center study, the description should include what's happening at St. Mike's, and it also should provide the context of the research. And I can't stress enough how important this is, because this is a section we read to sort of provide the context for how we review the rest of the application. If we understand what's happening here, then we can better review the implications of what you say later on in the application. For example, one of the things that often doesn't become clear, and I recently had a study like this, was I reviewed the TAS and the protocol, and I was halfway through the consent form before I realized it was a study procedure that was embedded in a research course, in an academic course, which has a whole bunch of other questions you need to be asking. So, and then there've also been instances where it seemed that all we were doing here was recruitment, so we only reviewed the posters, and then in a response we found out it was, oh, actually, no, we're doing interviews and observations, and at that point we then need to do a full review of all these other documents. I think my record might be I had a 4-page follow-up letter when I realized in the first set of responses what was actually going on in the study. And then we've also had the reverse happen to us, where we've done this full review and had a lengthy review letter, and then they're like, oh, all we're doing is putting up a poster. Like, oh, okay. So, like I said, this is really important just for helping us to frame how we're going to conduct the rest of our review. This section on clinical trials registration, for a lot of delegated studies, it's often left blank, and I think that's because it falls sort of in the section with the regulatory information about Health Canada and stuff like that, and people assume that they're related and just sort of move on to question 12. But please complete it only if to say it's not applicable because it doesn't meet the ICMJE, I never get those letters in the right order, definition of a clinical trial. Because it's not always obvious, because the definition that they use isn't limited to just drug and device intervention studies. It also includes behavioral, process of care changes and stuff like that. So it may well be, like, there may be delegated studies that do need to be registered for clinical trials, so just we ask that you provide an answer for that. And also, if your study does need to be registered, it has to be completed before you enroll the first subject, otherwise that could impact your ability to publish. So TASIN's question 15D takes a look at participants and enrollment timelines. So when completing this form, include the total number of participants in the study and also the number expected at St. Mike's. Break it down for all the populations being included in your research study. So if needed, it's like we're aiming to recruit 15 patients and 10 primary care practitioners and 2 hospital administrators, etc. If participants aren't being enrolled at estimation, like a literal sense, like they're not in the building, but they're being enrolled under the jurisdiction of the St. Michael's Hospital REB, they should be included in that number of participants enrolled at this site section. Just for, that's basically just for how we do our checks against your continuing reviews, that you're not over-enrolled. Also, provide responses for time period for enrollment and also the expected size of populations. These are often left blank in delegated review studies. And we do carefully look at these numbers to make sure that they add up and they make sense, that your recruitment targets are feasible. A lot of times people will say, oh, there's 20 patients a year and we want to enroll 20 patients in a year. And 100% enrollment isn't really feasible. And this usually leads to a month later that same study team coming back and saying, like, oh, we need to expand our potential participant pool by adding posters here or there. And so, again, amendments just add time to your ability to conduct your research study, because amendments turnaround could be anywhere from 3 weeks to 6 weeks. And so that just delays you being able to conduct that aspect of your research study. So if you consider it ahead of time, reduces the chance of that happening. Then this question, section 16, which looks at study interventions and procedures, is also often skipped a lot in delegated submissions because it assumes that we're only asking about study interventions and like the drug and device type studies. And to be honest, a lot of the questions are written are aimed towards those. But while not all of the sections apply to your study, we still do get some useful information out of these questions. So unless your study involves actual patient participants, you can usually skip 16A, which asks about standard of care. 16B asks about procedures that are not, quote-unquote, standard care, but for the purposes of REB review, this also refers to study procedures that are just outside of the normal practice of the individual. So if a physician isn't usually asked to do an interview about an education initiative, or a student isn't usually asked to complete a quality of life questionnaire as part of their academic requirements, that would sort of fall under the 16B section, and they should be listed here. So you would, in this section, include all interviews, questionnaires, and other research procedures that are specific to the research study, that are only being done because the person is in a research study. And again, continuing on 16B, so question 16. 16C asks about additional risk associated with the study, which isn't really going to be applicable to delegated studies because by definition, those are no more than minimal risk. 16D, however, would be applicable to most delegated as it asks about the time commitment needed for the research study. So this section should include the time commitment required by and frequency of any research-specific study procedure. So if it's part of routine academic or clinical practice, those don't need to be included, but anything that's research-specific should go in here. So things like we'll be doing questionnaires at 6, 12, and 18 weeks, and they're going to take 20 minutes each. Is sort of what we're looking for there. Moving on to recruitment methods. So all research advertisements, so posters, social media posts, like tweets and stuff like that, should have to be approved by the Communications and Public Affairs Office. They can sometimes take a week or two to get back to you with their review. So we recommend that you submit to them before or concurrent with the REB application, just to keep the ball rolling a bit. Before we issue approval, we do need their sign-off, and so a copy of an email from Jeff usually saying that they've reviewed the materials and they're okay with them. For other things on the recruitment methods is Snowball recruitment, so it should be provided in the application. There isn't really a space for it. I know a lot of things we ask, like isn't actually clear about meeting it. So in the other section, you can provide details of the Snowball recruitment. So what we're looking for here is that people are being asked to send information on to potential participants rather than providing the research team with contact information for the potential participants. So because of participants, sorry, a person's contact information shouldn't be shared with the research team without their explicit consent. So for Snowball recruitment, we always prefer that the research team ask that information be forwarded on rather than getting contact information. And then just describe how this will happen, whether or not, how they'll be asked to forward the information. Are they going to be given a flyer or an email or something? How the Snowball recruitment is going to work. And one thing to be careful of with email forwarding is that some institutions consider email forwarding to be a recruitment activity. So before you ask someone in another institution to forward an email to their colleagues, you should check with that institution that they don't consider that a research activity that requires ethics review. This has happened where we've gotten an angry letter from another hospital asking, you know, what are you doing? And also a good idea is to include it in the text of the email that you're asking someone to forward on, but please don't forward with, please don't forward unless you're sure that, you know, your institution doesn't consider this a research activity requiring approval. Make sure it's somewhere clear where they can see it, not buried in the middle of a paragraph, because it's kind of important. And like I said, there are angry letters, and we get them. And
question.
Yeah.
If we do end up having to seek REB approval at other institutions, do we need to contact St. Mike's REB to inform them that other institutions?
Yeah, we should be. Yeah, we should be told about other, especially for the gets to the point we become the lead site. So we should be told about other institutions that come on board. We've got that information in our file, and we'd also just want to make sure that if anything like contracts are taken care of also. So yeah, we should be told about that. And we don't have very good uptake on this, but we do ask for copies of the REB approval letters from the other sites. We don't always get them, but we really try to get copies of the approval letters, especially where we're the lead site. And then one last point for this section is just be sure to, if you're using advertisements and posting them, just be sure to include where they're being posted, either with tweets or Facebook pages or anything like that. Just let us know where ads are being posted. And the communications group will probably ask you for that information also. Then moving on to recruitment, initial contact should be made by someone who's known to the potential participant. So it shouldn't be like the research assistant walking up to someone in a waiting room or sending out an email to a group of residents that they don't know. Part of the reason for that is privacy. The research assistant shouldn't have access to someone's identifying or health information without their consent. So it should be someone who's known to the individual. If the person's doctor, supervisor, professor is part of the research team, we prefer that the initial contact with the participant is somebody else because it can be a bit coercive. The person might feel compelled to agree to hear more about the study or participate in the research because they don't want to upset their professor or their doctor. If that person really is the only one who can make the initial contact, with justification, we can be okay with that. But we, as much as possible, try to avoid that happening. And lastly, if you're cold calling someone or making contact through someone they don't know, they should be told why they are being contacted and how their information was obtained. And generally, we'll only approve a cold call approach for people who have publicly available information, like healthcare practitioners or certain government ministry individuals or stuff like that. Just want to do a short bit on this section 19A2, asking about potential harms of the study because it's not generally applicable to delegated review studies, but one particular case where it would be is for studies that have questionnaires that deal with sensitive and potentially upsetting subject matters that might cause the participants distress. So if you're asking questions about intimate partner violence, drug addiction, death of a family member, these can all be upsetting things. Also for studies that involve quality of life questionnaires where you might reveal that someone's experiencing severe depression or suicidal ideation or something like that. In both of these cases, we would want it to be listed as a potential harm. And we're also going to ask what the study team's management plan is for that. So this could be anything from referring them to another hospital department, providing a list of community resources that are available to them, contacting emergency services, or if there's no follow-up plan by this team, you can explain that. And sometimes that's just a matter of, oh, well, we're only reviewing all of the responses in aggregate a year after the study ends. So at that point, there's nothing really to be done. So just we want to know what the plan is and explanation if there is no plan. This is on the remuneration section. The main takeaway here is going to be that participants should not be out of pocket as a result of participation in research, and also that any gift or token of appreciation shouldn't be so coercive, like so high as to be coercive. Like, I'm going to give you $1,000 to answer my 20-minute questionnaire study is kind of out of whack with what's that, a sort of reasonable compensation. And so things that out-of-pocket expenses include TTC tokens or parking at the hospital if you're asking them to come in for interviews, or the cost of postage stamps if you're asking someone to mail in questionnaire responses. It's a meal if you have them coming in for like an 8-hour study visit and they need to have lunch in between, the cost of the meal. These are all considerations when you're sort of determining how to reimburse people for out-of-pocket expenses. Some studies also provide compensation for time, particularly for studies that are very involved. So if your study has groups, like a variety of study groups, compensation between the groups can be different, but it should be equitable. So not necessarily equal, but it should be fair. So for example, if you may choose to compensate physicians at a higher rate than the general public because their average wage is generally higher, or you may compensate people who participate in a 3-hour focus group more than someone who participates in a 1-hour interview. Like, these are all things that are equitable. Things that would be inequitable are, we're going to give people with diabetes less money than a healthy control because people with diabetes may have a health benefit from it. That's not really equitable compensation for someone's time. Then this section 23A, it gets answered inaccurately a lot of times. Sometimes it erroneously states that there's no PHI being collected, and other times it doesn't include everyone who has access to PHI. There's quickly definitions up there. PHI is any personally identifying information about an individual in oral or recorded form, and about their health or their health care. So it includes information on family medical history, or even things like who their health care providers are if you're recording those sort of names. That's considered PHI. So anyone, including external investigators and service providers, so like if someone's doing the transcriptions for your study, if they have access to identifying information in conjunction with health information, they should be listed in this section, along with the reason that they'll have access to the information.
What if, because we have, I know that it comes across your desk quite often where we have in the past not said that the research team will have access to PHI, but within the definition of PHI, does that include names, addresses, emails, like their contact information?
That's personal identifying information, but not personal health information. But I think a lot of times for the purpose of this question, sometimes even the privacy group reviews it, they consider that to be.
And then it's gone. And then it came back to us.
And then so I guess you could err on the side of caution and say that maybe, as explained, we aren't collecting personal health information, but the following individual will have access to personally identifying information, but no health information, and then that way sort of cover all the bases there. That's what we've been
doing now, so to avoid it coming back to us, we just indicate no personal health information, but personal identifying information. And then
and I think that's probably best practice for now. While these are the questions in the past that we're dealing with, that's probably the best way to go about it. So this section asks about the identifiable information that you're collecting for a study. So one common error is that it gets filled in with information that's collected during the conduct of the study. That's for question 25. So when you're completing this section, it's for information that's being collected during recruitment. You should be mindful not to collect more identifying information than is needed. So consider the purpose of each data point you collect. Like, do you really need someone's mailing address if everything's going to be happening by email or in person? Full date of birth should not be collected unless it's absolutely needed. If you need to know someone's age, ask them their age and write the age down. Or if you need to be specific, month and year should suffice. There's very, very few studies, especially if you're not dealing with like babies or neonates, where you need to know someone's exact date of birth. There isn't really a spot on the tasking form for it, but one tip I can offer is note somewhere on the form in this section how you'll be, like the format you'll be recording date of birth in, like month and year only. So that'll just save us from asking you the question, because I promise you we will ask you the question. So if it's on there, we don't ask it, you don't have to answer it. And lastly, the information listed here should match the identifiable information columns of your master linking and screening logs, because those are the only places where identifiable information should be recorded. So I will always do a check of the columns of your master linking log against this section, and I'd say less than 50% of applications that I review have a complete match between the two of them. Now just running through quickly some common data storage comments. If you indicate to us that you're storing data on a laptop or desktop, we will recommend that you store it on an internal server instead because it's more secure and regularly backed up. If you're using a third-party server, provide the name and location of the server. And USB keys, I'll be honest, we really don't like USB keys. They're so easily lost or misplaced. And then they result in privacy breaches, and it's a lot more work for everyone. So if you have to use a USB key to conduct your study, make sure that it's a USB key that's encrypted by our IT department or purchased through a vendor recommended by our IT department. I think because they only go to a certain size internally. If you need something bigger, go through them to find out who to purchase one from. Under the security measures section in 25F, you should select all the measures that are being taken to protect the privacy of study data and also ensure that this information is reflected in your consent form. So standardly, consent forms include things like where data is being stored and for how long and stuff like that. If your study involves audio recordings, be sure to indicate when they will be destroyed. That gets those checkboxes at the bottom there get missed a lot. And one big thing for this section is the checkboxes for de-identified, anonymized, and anonymous data. I've reviewed a lot of studies where all three of those are checked off, and in almost every case, that's just not possible. So I'm just going to do a quick review of the definitions of those three terms. So de-identified means that identifiers were collected or are collected, but they're removed from the data and replaced with a unique code or ID number. The identifying information is then stored elsewhere with a link to the unique code. So as long as there exists a document that is accessible that links the ID number to the identifiers, the data is deemed identified. When you destroy the linking log and you can no longer link identifiers to the study data, that's when the data is deemed anonymized. And information is only considered anonymous if identifiers were never collected in the first place. So based on these definitions, you can see it's fairly impossible, unless you're doing a complicated multi-part study, for data to be both de-identified and anonymous. So just keep that in mind when you're completing that section and only check one of them, at most two, like de-identified and anonymized. But yeah. Good? Oh, then this section here, 25G, the reason I'm bringing this up is particularly 25G, is that oftentimes in response to this question, or as in 25F, study teams indicate that data will be anonymized after the data has been collected, verified, or analyzed. This part's a little confusing because I know we give you those options on the TASN, but after discussions with Velma, who's our research compliance and education specialist, it was determined that the master linking logs are actually considered essential study documents and have to be retained as per the guidelines on retention of documents. So at SMH, that is 25 years for Health Canada studies, 7 years for clinical trials, and 5 years for all other studies. So data actually can't be anonymized for at least 5 years after completion of the study because you have to retain the master linking log as an essential study document. So that's probably something we're going to look at the next iteration of the TASN form because I know we kind of lead you there by giving you options for it.
So for the knowledge translation program, most of the things that come across your desk, it would be a 5-year retention? Yeah, it would be 5-year retention because they fall under the other study category. What if we're working with another institute that has different retention times? Do we indicate? You would follow the longest one, and if we ask for a justification for why you're keeping things for longer than necessary, indicate that institutional policy. And again, if you know this information ahead of time, just type it in there, and we don't have to ask. Okay. And so that means the master linking log has to retain for 5 years. Yeah. And then once it's destroyed, then your data becomes anonymized. Yes. So in that question, as a lot of people try to say, oh, well, as soon as the analysis has been complete, and I think that's what privacy would like us to say, but that's not what our research compliance specialist wants to hear. So there's a bit of a disconnect there. Section 25O, so harms if PHI is released. So this is another question that's often left blank or sometimes answered with not applicable. There's absolutely no possibility that PHI will ever accidentally be released. So while it might be extremely unlikely, there may be some unforeseen circumstance where PHI might be released. And if your study collects PHI, you should
included an answer to this question. You include the harms that could arise to the participants, to relatives, or to others, and be sure to include how the consequences will be addressed. It's not in bold like the rest of the question, so that gets missed a lot. At the minimum, the response should include informing the Privacy Office. Then lastly, contracts and research agreement section. So we approve research studies without a fully executed contract, but if one is needed, we require just confirmation that the contracts office is aware of it, and it's under review before we proceed with the approval. For large multi-center studies or studies where you've got an industry sponsor, it's fairly obvious that you're going to need a contract. But other situations where it might not be as clear to the research team is if you're using external services for transcription or data analysis, or if you're transferring data to an external co-investigator, or if contact information is being sent to another institution for recruitment purposes. Many of these activities do require a contract or service agreement, and if you think you might need one or are unsure, just get in touch with the contracts group, research.contracts@smh.ca, to get the ball rolling on that. So that pretty much wraps up the common comments on the TASN form. I've also prepared a few slides on common comments that I make on study documents that are submitted along with the TASN for initial review, because sometimes the comments on those are at least as extensive as what we say on this for the TASN. I'll quickly run through some of the common concerns that crop up in the review, and of the consent form, introductory letters, survey landing pages, interview guide, preambles, and also data collection forms. I've got several points, as you can see, listed on each slide, but in the interest of time and also because some of them are fairly self-explanatory, I'm only going to talk about a couple per slide. So for the consent form, use lay language. This isn't as applicable if your study involves only physicians or residents or any other group that is familiar with high-level medical or scientific terminology. But for all other groups, please ensure that the consent is understandable at a grade 7 level or lower. Make it clear that the individual is being asked to consider participating in a research study. This, I think, might be a St. Mike's specific peculiarity because I don't really see it on a lot of other consent forms, but we're fairly adamant that the participant is to be invited to consider participating rather than invited to participate, because that's one of the main points of a consent form is to give the person the information they need to consider before making an informed decision about participating. And then another point of consent form is if you're conducting interviews or questionnaires with free text fields, include whether or not direct quotes will be used in publications. This is something that's applicable to a lot of the delegated review studies that we see. Also note in the ICF whether the quotes will be attributed to the person or if any potential identifiers like where they work might be included in the quote or stripped out of it. Continuing on in consent form, the focus group consent form should contain a reminder to keep the information that was discussed confidential, and also in the privacy section a disclaimer that you can't guarantee that the discussion will remain confidential. For student participants, and this is probably one of the most important factors to them, it should be noted whether or not their instructors who are study team members will know if they decided to participate or not, and also whether or not the participation will have any impact on their academic evaluation, either directly or indirectly. Like, for example, an evaluation done as part of a research study might not actually make it into their formal academic evaluation, but if somebody is part of a study with a surgical simulation and they do really badly on that, it might impact how their instructor just views their skills for their academic components. And then also, the information consent statement, some consents we see include a one-liner saying, yep, I agree to be in the study. Others are these page-long behemoths from industry saying, I consent to allowing you to use my data for whatever you want to forever and ever and ever. We've got standard wording for this section, and it falls somewhere in the middle of those two, and we just ask that it be used in every case, and also that the statement of consent and all participant signatures all fall on the same page as each other. For introductory letters, some common things that we ask for when reviewing introductory letters are including how someone was identified as a potential participant and how their contact information was obtained, what the next steps would be after the participant responds. So sometimes it says, if you're interested in participating in the study, please let us know. But it doesn't say, we'll contact you to schedule an interview, or you'll be given 3 time slots for focus groups. So this should be information of just to letting them know what to expect back from the research team once they respond. And then also we ask that you include a section saying if you're going to be sending reminder emails for completion of a survey or to get back in touch with you about participating in an interview, that they be told in advance what the frequency of that follow-up contact is going to be, and that they be given the option to opt out of that. So if you don't want to hear, like if you aren't responding because you don't want to be part of the study, you don't necessarily want 3 additional emails inviting you to be part of the study, so giving them a route to not have that happen. For survey or questionnaire cover landing pages, so if your survey has a separate consent form, some of this information is covered in the consent, but we'll still ask for a landing page or cover page with these reminders to be included, particularly for studies where there's a gap in time between when they sign the consent form and when they are completing the questionnaire. So just some things that should be included are like an estimate of how long the study is going to take to complete, that they're free to stop the survey at any time, and what happens to the information they've entered to that point. So will already submitted answers be retained if they're like halfway through our survey, for example. Let them know a date by which they should complete or return the survey, because, well, that's just good practice. And if applicable, let them know that their consent is implied by completion and submission of the survey. Similarly, for interview guide preamble, some of this might be covered in a consent form, but again, it's good to remind them of these just prior to starting the interview or focus group. So include whether or not the discussion will include sensitive topics or questions that may be uncomfortable. Let people know that they have the option to skip questions or to pause the interview or end it at any time. Remind them if the discussion is going to be audio recorded and the expected length of the discussion. And again, if you're using an applied consent model for interviews, remind them that by participating in the interview, their consent to participate is implied. Then just a couple notes on data collection forms. As I mentioned, identifiable information such as MRN, date of birth, initials even shouldn't be recorded on the data collection form. They should be kept separate from non-identifiable information using the master linking log and a unique study ID number. Sometimes for questionnaires, they'll include a lot of demographics questions, but when considered together, these can be potentially identifying, especially if you're dealing with a small group, like say you're looking at the otolaryngologist at St. Michael's Hospital. By the time you've asked them for their gender, their age, and how many years they've been in practice, you can probably figure out whose questionnaire that is. So consider whether or not all of those data points are needed to meet the goals of the study, and ask for the minimum number of demographics questions needed. One field that I always ask questions about is a fairly nondescript other comments box, because I have really no way of knowing what you're planning on capturing there. It could be anything. And so you should only be collecting data that's needed to meet the objectives of the study, and you should be fairly explicit about what that data is. So when other comments field, it shouldn't be necessary, and if it is, justify why and the kind of data that you plan on collecting there. So that more or less wraps up the sort of things we look for in initial review. Just quickly, some other common concerns that come up and that will affect review times, quality of review, or your ability to conduct your study in a timely manner is copy-paste errors when we're using old forms. If you pull up the tabs in because, hey, it's got most of the information filled in already, we're just going to change a few things, but you don't catch everything, and suddenly I've been looking at a study about questionnaires for breast cancer, and suddenly in question 20, you're talking about interviews for people with kidney failure. And so we're going to ask questions about that. We're going to flip through the protocol trying to find what you're talking about, so it takes up more of our review time, and we're going to ask you questions that you don't actually need to be answering. Version dates. If you could update these after each round of review, that's really helpful to us, because that's a good way of us tracking what actually gets approved. Because if you submit studying something like a May 2017 version date, and through the various rounds of review it never gets approved, but there's 5 iterations of it, and then we issue an approval letter for the May 2017 version. Somebody auditing that study or somebody just coming into the study has no way of knowing which of those 5 iterations is actually the version that they should be working off of. So we don't, like mandate it, but I really, and I think I will push that we mandate it, but right now I'm strongly encouraging people to update conversion dates after each round of review. Departmental sign-off, if you're recruiting from other areas, you're going to need, if you're recruiting from like Emerge or Family Med, you're going to need their sign-off. That can sometimes take a couple of weeks for them to review it, so get to that early if you can. Another thing that's been happening a lot recently, particularly I think with the knowledge translation protocols, is within a month or so of me issuing the approval, I get an amendment altering the recruitment process because you haven't been able to meet the recruitment targets or the numbers or just something. It's usually a to do with recruitment, and it's usually within a month or two of referring the study. So just before you submit the application, just carefully consider all aspects of the study. Are the outcome measures being met, or do all the, do you need to add an additional questionnaire? Is the recruitment plan appropriate? Do you need to change your inclusion and exclusion criteria? Do you need to expand where you're putting up posters or your potential participant pool? Because each amendment, it comes in, I usually take about 3 weeks until I get to it. I issue the review questions, a week to get to you, a week back to me. That's a 5-week delay in your process. So these things, I know people are eager to get initial approval and get the study started, but if you're going to have a 5-week delay 3 weeks in, it might be worth it to just reconsider this for a couple extra days at the beginning to avoid the delay later down the road. And that is the end. So that's just, okay. There we go. That's just contact information. We all, like this, all the research coordinators, any of us is always happy to answer any questions that you have, meet with you if you have a particularly difficult study or problem, get in touch with me. I'd much rather discuss these things ahead of time than in the middle of review. So always available, please get in touch. And that is the end. All right. Any last minute questions or general questions? All right.
You guys do like a Christmas round, so you just show the financial.
We should do that. One of our vice chairs, Philip, he has like typical doctor handwriting. So we are thinking about starting just a slideshow